Hi, my name is George Puente. I'm head of the Medical and Regulatory Group for the Japan and Asia region. Every year, millions of people die of cancer. We're beginning to bring medications to treat this terrible condition and improve patients' life by prolonging as well as improving the quality of life. Normally, we train salespeople to do what we normally do at the company. However, this is the first time we're actually going to be training regulatory people to understand what these medications do, what their potential is, so that you can discuss this with your regulatory authorities. Very unique, and we feel that our investment in this process will be very beneficial to all. I hope that you find this program not only valuable, but very useful in your future endeavors and discussions with the various regulatory authorities. Good luck on this new challenge ahead. Thank you.
For decades, Pfizer Global Research and Development has been actively conducting research in oncology in an effort to discover new molecular entities in the fight against cancer. As a result of Pfizer mergers and acquisitions, our oncology portfolio of marketed products now encompasses cytotoxic drugs such as pharmarubicin, which has been shown to improve 10-year survival in patients with early breast cancer when used in combination chemotherapy, Camtasar, which has been shown to improve survival in patients with colorectal cancer, as well as aromacin, a hormonal agent which has prolonged progression-free survival in women with early breast cancer following tamoxifen treatment.
Currently in phase 2 and 3 clinical trials is one of those new molecular entities developed in Groton, New London and called tisolimumab, a monoclonal antibody CTLA-4 antagonist, which is being evaluated in malignant melanoma. To these oncology drugs which Pfizer can offer patients and their oncologists, we have now added Sutent, a multi-targeted tyrosine kinase inhibitor, which is both an anti-angiogenic and an anti-proliferative agent. Sutent targets VEGF receptor, vascular endothelial growth factor receptor, and PDGF receptor, platelet-derived growth factor receptor, on tumor cells, tumor blood vessels, and supporting connective tissue cells, which surround tumor blood vessels. Pfizer has recently received U.S. FDA approval for Sutent, as well as EMEA approval in Europe, and recent approval in Indonesia in the treatment of Gleevec-resistant GIST, gastrointestinal stromal tumors, and advanced renal cell carcinoma, kidney cancer. We expect Sutent approval in Korea in 2 months.
For some Pfizer regulatory colleagues, the field of oncology may seem overly complex. Yet there are some basic principles of all solid tumors, which I would like to spend a few minutes here reviewing with you.
While it is true that each tumor from a specific organ needs to be viewed as a unique entity with specific patterns of general behavior distinct from tumors which arise in another organ, there are certain principles which can be generalized to most solid tumors. Tumor staging is one such basic principle. Stage is defined at the time of initial diagnosis of the tumor. Is the tumor localized to the organ in which it arose or not? Has it spread to draining lymph nodes or not? Has it spread via the bloodstream to distant organs or not? This is why many diagnostic tests are performed at the time of initial diagnosis, including tests such as CTs of the abdomen, chest, or brain. These diagnostic tests help stage the patient and tell the oncologist whether disease is localized or not. Treatment decisions are based on tumor stage. In order to decide whether a patient fits into the category of potential cure or not, the disease must be identified as being localized. If it is localized to its original site and draining lymph nodes, it may be considered potentially curable via surgery and/or radiation. If, on the other hand, the disease has already spread to distant organs, there may be no chance of cure with surgery or radiation. Goals then become palliative. Attempts at shrinking the tumor or preventing it from enlarging and causing increasingly severe and debilitating symptoms may be discussed with the patient, and chemotherapy may be considered, since chemotherapy can reach areas of tumor which may have spread beyond the organ in which it originated.
A clinically useful classification scheme for any cancer must encompass attributes that define its behavior.
The AJC Classification, American Joint Committee on Cancer, is based on the premise that cancers of the same anatomic site and histology share similar patterns of growth and similar outcomes. As the size of the untreated primary cancer increases, regional lymph node involvement and/or distant metastasis become more frequent. So, these three significant events in the life history of a cancer, local tumor growth, T, spread to regional lymph nodes, N, and metastasis, M, are used as they appear on clinical examination before definitive therapy begins to indicate the anatomic extent of the cancer. TNM is a shorthand method of defining disease stage, and this always refers to stage at time of diagnosis. Because spread to regional lymph nodes and/or distant metastases may occur before these tumor cells can be detected on a clinical examination, diagnostic procedures, such as diagnostic biopsy, can provide histologic pathologic confirmation of a tumor diagnosis and provide information on extent of the disease. If a subsequent surgical procedure is performed, examination of the surgically removed tissues may identify significant additional indicators of the prognosis of the patient. This additional pathologic classification, that is PTNM for pathologic TNM, is recorded in addition to the clinical classification. It does not replace the clinical classification.
As a way to further understand how tumors are diagnosed and staged, I'd like to share footage from 2 gastroscopies with you. A gastroscopy is a commonly used diagnostic procedure to detect cancer of the stomach. Stomach cancer is one of the most common cancers in Asia. Most patients with stomach cancer are diagnosed with advanced stage disease, and this is reflected in the vague, nonspecific symptoms. Patients may experience a combination of signs and symptoms such as weight loss, anorexia, fatigue, or epigastric discomfort, none of which unequivocally indicates gastric cancer. Upper endoscopy is used routinely for the initial diagnosis. The size, location, and morphology of the tumor, including the proximal and distal extent of spread, as well as other mucosal abnormalities, should be carefully evaluated. Decreased distensibility of the stomach, abnormal peristaltic activity, or abnormal pyloric function may indicate extensive submucosal infiltration or extramural extension of tumor. The likelihood of a positive yield on biopsy is greater than 95% when 6 to 10 tissue samples are obtained. Sometimes endoscopic ultrasound is used to evaluate depth of invasion of the primary tumor. Preoperative CT of the chest, abdomen, and pelvis are useful for assessing the lateral extension of the tumor and presence of systemic metastases. Despite these tests, 50% of patients have more extensive disease at laparotomy than was predicted by preoperative CT. Once disease is metastatic, local modalities such as surgery or radiation are insufficient to achieve cure. For stomach cancer, the most important prognostic factor is involvement of the draining regional lymph nodes. Depth of invasion of the stomach wall is also an important prognostic factor.
Systemic chemotherapy may be considered depending on the patient's overall condition. For stomach, there are several histopathologic subtypes. These are all epithelial in origin, that is, tumors which arise from the lining cells of the stomach. 95% of all malignant gastric neoplasms are adenocarcinomas, and in general, the term stomach cancer refers to adenocarcinoma of the stomach. Response to treatment can vary depending on specific histopathologic subtype. This is true for different chemotherapeutic agents. You will note that GIST, gastrointestinal stromal tumors, is not listed among the usual histopathologic subtypes. This is because GIST is a non-epithelial tumor of connective tissue origin. Until recently, GIST tumors were diagnosed as leiomyosarcomas, that is, a connective tissue tumor. With the introduction of Gleevec or imatinib and recognition that GIST tumors were responsive to Gleevec, pathologists around the world are properly diagnosing more stomach cancers as GIST rather than sarcomas. Pfizer's multi-targeted tyrosine kinase inhibitor Sutent, which is taken by mouth by patients, has improved survival in GIST patients who are refractory or intolerant to Gleevec. Particularly in Asian countries, stomach cancer is one of the most common malignancies. As you can see from data from Korea, the incidence of stomach cancer is higher than lung cancer and colorectal cancer, two of the most common tumors in Western countries. This represents an important unmet medical need in Asia and one which Pfizer is working to address. During the past year, Pfizer has initiated a phase 2 trial with Sutent in 4 Asian countries to evaluate whether Sutent is effective in slowing down the growth of gastric cancer in patients. To date, 22 patients have been enrolled in the study, and we look forward to results over the next year.